Hi, everyone. Thanks so much for tuning in today. It's great to see so many people interested in learning about sexual health and prostate cancer supportive care. For those of you who don't know me, my name is Michelle Fitzpatrick. I'm the sexual rehabilitation nurse with the Prostate Cancer Supportive Care Program. This presentation today is about 45 minutes long. I encourage you to look up some of the resources in your own time to supplement your sexual health knowledge. Here is a general overview for this presentation. I will be providing an introduction to sexual health and assessment, an overview of prostate cancer and the sexual consequences from treatment. Next, we'll talk about erectile dysfunction and some treatments. And finally, the Prostate Cancer Supportive Care Program with information about how to refer to our program. Here is a definition of sexuality and intimacy from our symptom management guidelines. I'll be providing information later in this presentation about this guideline and how to access it on the BC Cancer website. Sexuality is who we are, and it's an important part of being human. It encompasses our sexual identity and orientation, how we experience pleasure and intimacy, and it encompasses our sense of self and how we relate to others. Intimacy is how we feel close and connect with someone else, sharing our identity, having mutual acceptance, and it is more closely linked with communication. And these two are interconnected in our intrinsic sense of self and overall well-being. Now let's explore what is normal sexual function. This is the sexual response cycle as adapted from Masters and Johnson. Most people start with having sexual desire and arousal where they become sexually excited. Then an erection may occur, though it's not necessarily needed. Afterwards, you may arrive at orgasm or climax, typically coupled with ejaculation, a release of fluid. Then individuals will enter into the resolution and refractory period, and this is where another orgasm or erection is not possible for a period of time. Now, there are many contributing factors for sexual dysfunction. The ones listed here are from our symptom management guideline, and they are all cancer and treatment related. There are many more causes of sexual dysfunction. There can be physical symptoms, such as having changes in bowel or bladder function. It could be from side effects from medication. So if you're on an antidepressant or an opioid. Could be from body image disturbances if the patient is experiencing weight changes or hair loss. And also partner concerns. Many times for cancer patients and their partners, there is role changes where the partner moves into more of a caregiving role. So there's many ways cancer and treatment can cause sexual dysfunction. Now we know that cancer and the treatment of cancer can cause changes in one's health. Sexual health is a component in holistic well-being. And when a patient loses their sexuality, they lose that sense of wholeness. Research tells us that having sexuality and intimacy can lessen emotional distress and improve adjustment in the face of cancer. It helps to normalize the cancer experience and provides an escape from stress. Providing education about sexual side effects can help your patient to make more informed decisions and cope better with the consequences of treatment. Now let's take a look at some of our own statistics. In this survey, I asked you, how often do you discuss sexual health with patients? 35% said about less than once a month, 25% said a few times a month, and 14% said a few times a week. Only a quarter of healthcare professionals reported discussing sexual health on a regular basis, meaning a few times a week or more. And in this survey, I also asked you, what is your comfort level in discussing sexual health topics with patients? So you were asked to rate this on a scale of 0 to 10, 0 being not at all comfortable and 10 being very comfortable. The average from 27 healthcare professionals working at BC Cancer Victoria said about 5 out of 10. Most people would say that they are somewhat comfortable in certain areas of sexual health. And comfort level is just one barrier that prevents us from discussing sexual health with patients. And let's take a look at some of those other barriers, starting with patient barriers. Patients' relationships with their clinician can affect their reporting sexual health concerns. It can come from feelings of disrespect or low trust, discomfort in discussing sexual health concerns, or their perceived reaction from the clinician. So if they think that their clinician is going to respond poorly to them discussing sexual health concerns, then they're not likely to bring it up with you. It can also come from the patient's lack of knowledge about their general anatomy and physiology, sexuality and sexual health, or they may be misinformed about the sexual consequences of cancer and treatment. Another barrier can be their belief about sexuality. Many patients tend to think that cancer is contagious. They're afraid that it may spread to their partner. They may think that giving up sex may cure their cancer, or perhaps sex will worsen their cancer and cause it to come back. And so there's a lot of beliefs that can contribute to them not bringing that up. Also feelings of shame, fear, or embarrassment, or implicit trust in one's clinician, meaning your patient may think, if my doctor does not discuss sexual health, it must not be important. Now let's take a look at some of the barriers for clinicians. And as you can see, there are many. The main ones being no one takes responsibility, no one makes time for it, and it's not a priority. And it's often the case where healthcare providers will assume they are not responsible for addressing sexual health concerns with their patients. This leads to no one talking about sexual health, and the patient is left uninformed or distressed. This is why it's important to step outside of your comfort zone, make the time to talk to your patient, and seek out information and resources to expand your sexual health knowledge. And speaking of barriers, let's look at some common myths that I've heard at BC Cancer and many other healthcare facilities. And it's important to identify with which myths we're holding on to and how it's prevented us from providing the best care for our patients. So many healthcare providers think if it was important, the patient would bring it up. We know that this isn't true. A lot of the time, there are barriers that prevent the patient from bringing up, even if it is really important to them. Some people think that cancer patients are not concerned about sexual health, and that is not the case. Sexual health can be just as important as any other concern to a patient. It's good not to assume how a patient is feeling or what's important to them. Another misconception is that sex is only for young people. This is not true. Sex can be for all ages, and individuals can lead a healthy sex life up until the end of their life. There's no time for sexual health assessment. I believe that we have to make time, that we have to ensure it is a priority. It's only for disease prevention. We know that there's many different reasons for sexual health education. Or patients don't want us to ask about sexual health. Research tells us that the majority of patients do want us to ask, even if it does feel uncomfortable or embarrassing, and it's not coming from, the most important person. They just want someone to ask. No erection equals no sexual orgasm. That's a really common myth. Individuals can have lots of pleasure from orgasm and sex without erection. And finally, it's not our job to address sexual health concerns. It is everyone's job to address sexual health concerns if you are providing assessment and care to your patient. Now let's explore, how do we address these sexual health concerns and how do we open up that conversation? I'm just going to take some time to show you how to access the symptom management guideline for intimacy and sexuality. So here we are on the BC Cancer website, and you're clicking into Health Professionals and scrolling down to Clinical Resources and Nursing, and going into our symptom management and looking at these guidelines. And here you can find the Intimacy and Sexuality Symptom Management Guideline. And here's a look at that focused assessment on the first page. I highly recommend you look at this in your own time, as well as some key considerations and goals for management of concerns related to intimacy and sexuality. But I'm going to spend more time on something called the implicit model, as I believe this is one of the most important tools for opening that conversation and guiding you through the sexual health assessment. So the implicit model involves asking permission to raise the topic of sexuality, providing limited information to address patient concerns, giving individually tailored specific suggestions about sexual health, and referring for intensive therapy when needed. Now let's look at each of those in more detail. Giving the patient permission to discuss their sexual health concerns is very important. We know that there are many barriers for patients to report their concerns. Their therapeutic relationship with you is one of them. And it's our job to ensure the patient feels they are in a safe and comfortable environment to discuss their concerns. So you can start by creating some privacy, either in a room or in an area where they feel comfortable, and open that conversation by normalizing the topic and validating any concerns. You need to give your patient permission to enjoy intimacy and sexual activity, as many are unaware that they are able to do so. And I find a lot of the time when healthcare providers are new to discussing sexual health with patients, they wonder how to initiate that discussion. And so I provided some examples. For example, can I ask you some questions about your sexual functioning? Or have you noticed any changes in your sexual function since treatment? You can also provide or ask information in an educational way. So if you are listing other side effects, you could say for sexual health, you may experience erectile dysfunction and a lowered sex drive. You can ask the patient, is that something you'd like to know more about? So these are just some examples of how to open up that conversation. And just know that it takes time and practice. I wasn't always comfortable discussing sexual health concerns with patients. It's going to feel uncomfortable to start, just like anything that's new or challenging. But think of when you just started talking to patients in your training, and I'm sure that first conversation about bowel movements was pretty uncomfortable. Now it's integrated into our regular assessments. It's normal because we make it normal and because we've practiced. So the first step is just getting out there and trying to open that conversation with your patients. And after asking some questions and opening up that conversation, if you feel comfortable, you can provide some limited information related to their concern. And if you're new to BC Cancer or need a refresher on some resources, here's a list that may be helpful for you. Our website on BC Cancer and our librarian are very resourceful and can always help you to find more information about sexual health. And after this presentation, I recommend you explore some of these resources, including the recommended websites, and there's some information here of how to access this. And after providing limited information, you can also provide specific suggestions. And on this slide, you can see many suggestions that can enhance intimacy or initiate sexual functioning again, such as encouraging couples to build intimacy in whatever they find pleasurable, exploring mutual pleasuring, self-stimulation, use of sexual aids, but giving the patient permission to explore these things is important. And finally, it may be helpful to refer to another healthcare professional if your patient feels that they need additional support. And here's a list of some of those professionals that may be able to help you, such as counseling, a sex therapist or sexual rehabilitation nurse, the Look Good, Feel Better program. These are just a few examples of the many resources we have to help support your patient. And the most important points to remember is that most patients want you to ask, even if you're uncomfortable, don't have too much time, or don't have that much knowledge about the subject. Asking questions is the best way to support your patients. And remembering that you don't need to have all the answers. It's okay to say, you know, let me give you a call back, or I'm going to refer you to our sexual health nurse. But just starting that conversation is the most important message. Now let's talk about prostate cancer, as this is my area of specialty. And this next slide provides a very brief overview as to what prostate cancer is. And I won't spend too much time on this, as I know many of you are familiar with prostate cancer and treatment. But if you're new to oncology and needing more information about prostate cancer, there's a lot of great information on the BC Cancer website, or you can go to the Prostate Cancer Supportive Care Program website. Lots of resources out there to supplement your knowledge. Now, the prostate is part of the male reproductive system. It adds nutrients and fluid to the sperm. Normally, it's the size of a walnut and is located in front of the rectum, just below the bladder, and surrounds the urethra, kind of like a donut. And the growth of cells in the prostate, both healthy and cancerous, is stimulated by testosterone. And prostate cancer is the most commonly diagnosed cancers among Canadian men. 1 in 9 men will be diagnosed with prostate cancer. The risk of developing prostate cancer increases with age. Most of the time, it happens after age 50. And when prostate cancer is caught early, the 5-year survival rate is very close to 100%. Now let's look at some of the sexual side effects from prostate cancer treatment. And there are many side effects that can occur as a consequence of prostate cancer treatment. Here are some of the most common treatments listed, including active surveillance, which is no treatment or watchful waiting. We have prostatectomy, surgical removal of the prostate. We also have radiation therapy, including brachytherapy and external beam. And then we also have hormone treatment or androgen deprivation therapy. And the most common symptoms from prostate cancer treatments can be erectile dysfunction, painful or loss of orgasm, dry ejaculation, genital shortening, urinary and bowel issues, and other side effects such as fatigue, weight gain, rashes, hot flash. It really just depends on the treatment that they're receiving. But I'll let you look at this chart in your own time if you're interested in learning more about this. And here's some information about the timing of sexual dysfunction. As you can see in the charts on the right-hand side, active monitoring is shown in blue, prostatectomy in red, and radiotherapy shown in orange. In both surgery and radiation, there is an immediate loss of sexual function and erectile function in the first 6 months. There may be some minor improvement in functioning within the next 6 months for radiation, but typically for prostatectomy, it takes about 2 to 4 years until the patient regains that function. Yet, if you're looking at the graph, you can see at about 72 months, the sexual potency and erectile functioning is very similar among all groups, even without having any treatment. So you can see the blue line for active monitoring as there is a decline in function, and that's just related to aging. Now let's look more at erectile dysfunction. And here you can see is the mechanism of an erection. It is a very complex process, but generally the quick version is that erections are caused by physical or psychogenic stimulation. That stimulation sends a signal from the brain down into the penis, telling the smooth muscle to relax in the erectile tissue. This allows the arteries to dilate, allowing blood to flow into the erectile tissue. Blood accumulates, and that results in an erection. And there are many causes of erectile dysfunction. If a patient has prostate cancer treatment or several of these comorbidities, then that's the more likely they are to experience erectile dysfunction. Now, starting to look at some of those treatments, we'll start first with the pills. These pills are called PDE5 inhibitors or phosphodiesterase 5 inhibitors. And this discovery of the pills for causing erection was actually accidental. It was noticed as a side effect when being administered to investigate their ability to treat hypertension and angina. And that's what prompted the discovery of many other PDE5 inhibitors for erectile enhancement. Now, the oral therapies work by inhibiting that enzyme, PDE5. The enzyme is present in cells lining the smooth muscle tissue in the penis. And when we inhibit this enzyme, it causes the smooth muscle tissue to relax, and that allows more blood to flow into the penis, causing erection. Now, this is typically the first thing men will try, as the oral therapies are considered one of the easiest and least invasive therapies. Most men are comfortable with taking pills, and they all work similarly as they are the same type of drug. However, some men will respond to one brand more than another. So it's good to try them all, but at different times for your patient to see which one is most effective for them. For example, I've had some individuals tell me that They tried Viagra a few times, and each time they had a really bad headache and about 4 out of 10 erectile response, meaning, a little bit of penile swelling. And others, will say that then they'll try Cialis, and they had a really great erectile response with no side effects. So it's important that, if they're not receiving a good response after trying one a few times, that they're kind of moving on and trying a different pill. Now, there's short-acting and long-acting medications. The short-acting are Viagra, Levitra, and Staxin. They stay in the body for up to 4 to 8 hours and generally start working within about half an hour after taking them. The long-acting Cialis can stay in the body for up to 24 to 36 hours and generally starts working at about 2 to 4 hours after taking it. Now, this does not mean your patient will have an erection for 36 hours. It just means that they may have the potential for one. But it's really important to let your patient know that they need to have good sexual thoughts and stimulation after taking the pills. Your patient can't just take a pill and be reading the newspaper, waiting for something to happen. They have to have those thoughts and stimulation. There's a daily and on-demand dose that they can take. Many patients will take a daily low dose of Cialis or Viagra for something called penile rehabilitation, which is basically stimulating blood flow into the erectile tissue to keep it healthy. And many patients will want to do penile rehabilitation after surgery or radiation to ensure that their tissue stays healthy. And so others will also take the pills as a higher dose for sexual activity. Now, potential side effects can be facial flushing, nasal congestion, blurred vision, particularly with Viagra, headache, muscle aches and pains, typically with Cialis, and hearing changes or indigestion. Contraindications, this may not be appropriate for any patients with heart conditions where they're using medications with nitrates, such as a nitro spray, or blood pressure medications. The reason for this is that these pills already cause a decrease in blood pressure. So if the patient is taking multiple medications to lower their blood pressure, the combination can cause severe hypotension. It's also important to consider your patient's erectile nerve function and level of testosterone. Sometimes prostate cancer treatment can cause damage or remove the nerves that are responsible for forming erections. And these pills rely on those nerves to be working to be effective. So it's important to consider that status and let your patient know if you think it'll be effective or not for them. Also, if your patient has lowered testosterone, such as if they're on hormone treatment or androgen deprivation therapy, these pills may not be effective for them as they do rely on some testosterone to work. But that being said, I've had some men who are on hormone treatment or those who have had a non-nerve sparing surgery, and they have responded to the pills. So it doesn't hurt for the patient to try, yet being informed is important, letting them know that if it doesn't work for them, then there's alternatives that they can try. Some other notes is that the pills can sometimes be affected by fatty foods and alcohol, specifically Viagra and Levitra. So recommending your patient takes these on an empty stomach, as fatty food reduces the dose by 20 to 50% and increases the time to absorb by 2 hours. So making sure that the patient takes that into consideration. And looking next at Muse. This is administered via suppository. The medication called alprostadil is delivered directly into the urethral lining. So it gets administered into the urethra, and it's absorbed into the corpus spongiosum, or an area of the penis. It is then transferred through collateral blood vessels into the corpora cavernosa, or the erectile bodies. And typically it's absorbed within about 10 minutes. It looks as though it might be uncomfortable, but it is actually quite well tolerated. That being said, it's not commonly used in Canada as it's quite expensive, about $40 to $70 per dose, and not typically covered by insurance unless they have extended benefits. And it also only works in about 40% of men. That being said, I've heard men in the UK love using Muse as it is covered in their healthcare system. So just know that it is used just in other parts of the world. It's not appropriate for all patients though, particularly if they have any urinary incontinence. The medication will not be absorbed properly, and this could also cause some irritation if some of the medication leaks out into either a vagina or anus for penetration activities, then that can cause an issue for the partner. Next, we'll look at penile injections, also known as intracavernosal injection therapy, or ICI. It's one of the most effective erectile dysfunction treatments. It's about 90% effective and one of the most affordable therapies, especially compared to the pills, which average to be about $12 to $19 for one pill. The injections typically work out to be a couple of dollars per injection, though it depends on how much the patient needs. Now, the injections typically work better than the pills as they are not reliant on the erectile nerve function or testosterone to be effective. It's a very local response where the patient injects a small amount of medication into one side of the penis, which causes that smooth muscle tissue in the penis to relax, allowing blood to flow in and forming an erection. And the patient only needs to inject a small amount of medication on one side of the penis to form a full erection. Most patients like the injections once they get started, as it produces a really good quality, long-lasting erection, ideally lasting 30 to 60 minutes or however long is pleasurable for the patient. And it creates a more natural looking erection than some other therapies. So it'll be more used to what their natural state would be. What's the biggest problem? It's mental image. As we know, a lot of patients are hesitant to try injections, especially in the genital region, as they're afraid it will be painful, or people don't like needles. I will say it's a very small needle. Most men don't even feel it. We use insulin syringes. But the most challenging part is psychological and just getting your patient comfortable with the technique. And that's why I do one-on-one teaching with the patient and their partner about how the medication works, how to draw up the medication, different holding techniques, how to inject. We spend lots of information making sure, or lots of time making sure the patient has the correct information and is comfortable going home doing it on their own. Now, there's several different types of medication you can prescribe for injection therapy. The most commonly used one in our clinic is Trimix, and that's a combination of alprostadil, papaverine, and phentolamine. There's also Bimix and Prostate. Possible risks. There's a very small risk for something called priapism. That's a prolonged erection. About 0.2% of men experience this with injections, or scarring in the penile tissue, causing penile curvature, called Peyronie's disease. Again, it's a very small risk for this, but it's always good to inform the patient and prevent the risk for this with teaching. Next, we'll look at vacuum therapy. These were commercially made in the 1980s. The one on the top right, called the Osborne-Erecade Esteem is a medical grade vacuum pump device. It includes a vacuum cylinder, a pump to create a controlled negative pressure or vacuum, and sometimes it will come with tension bands and a loading device. Now the cylinder is placed over the penis and held against the body. The patient needs to use a lot of water-based lubricant to ensure a vacuum is created. The pump is then activated, either handheld or battery operated, to create a controlled vacuum. I recommend the handheld as I see men typically like this for more control over the pressure. Once engorgement of the penis is obtained, the pressure can then be released. Now, these steps are typically repeated for penile rehabilitation. That's doing exercises to keep that tissue healthy. Or after engorgement, the patient can put a tension band on the base of their penis, and that ensures the erection stays firm for intercourse or other sexual activity. Again, our clinic recommends the medical grade ones, such as the Osborne-Erecade, as they are more effective in producing penetration firm erections, as I see that they typically have less air leaks in them and the patients do better with them. They're also tested and certified to deliver a certain amount of pressure in the cylinder to ensure that no damage is done to the erectile tissue. That doesn't typically happen, as most patients will stop pumping if they feel any pain, but it's always good to have that reassurance. Now, patients do not need a prescription to obtain a medical grade pump. They can simply just go online, or sometimes pharmacies will carry them and pick them up themselves. Sometimes patients can be covered for extended benefits, and it may be helpful if you write your patient a letter just saying that they need a medical grade pump for penile rehabilitation. And I do have a template for this if you're needing that for your patient. Some side effects can include penile pain or bruising, especially if they're kind of pushing past that limit of pain. Also, penile discoloration. This isn't anything harmful necessarily to the patient, but just from drawing some blood from the veins, so it can create a bit of a dusky blue tinge, might be a little cold to touch. And for couples who are using the pump for sexual activity, I just recommend putting a bit of lubricant on their hands and warming the penis up. And that can kind of ease any discomfort. As well, sometimes the tension bands can create a bit of a hinge effect, as the blood circulation is only from the base of the tension band to throughout the penis, whereas normally an erection would stay firm throughout the body into the pelvis. And so with that hinge effect, I always recommend that couples just use a hand to guide the penis either into the vagina, sex toy, anus, or mouth first before starting to engage in sexual activity. And finally, we will take a look at the penile implant. It is a permanent procedure, so once the patient has the implant, they can't go back to using pills, the injections, or a pump. And it requires surgery to place the implant. It's about an hour to an hour and a half surgical procedure, and it is covered under the Canadian healthcare system. So it's 100% free of charge for those individuals. Now, the benefits of the penile implant is that it's very effective. It takes about 10 seconds to form a 100% rigid erection. And 90 out of 100 men say that they are satisfied with their penile implant. For the 3-piece penile implant, as shown in the top right picture, there's a pump in the scrotal sac, a fluid reservoir in the pelvis, and 2 cylinders which replace where the erectile bodies would be in the penis. And basically, the pump is activated and the fluid moves into the cylinders, causing an erection. And then when the patient is done, they press a release button where the pump is, and then the fluid goes back from the cylinder into the reservoir, causing flaccidity. So doctors will usually wait about 2 years after treatment to ensure that the patient has achieved the best possible recovery for natural erection. You may remember that it can take quite some time for those erectile nerves to heal, between 2 to 4 years after prostatectomy. And so that's why typically doctors will wait before considering this option. Another thing to let your patient know is that it doesn't extend the length of the penis at all. So I always ask the patient if they want to have a good idea of how the implant would look, just simply pulling their penis out while it's not erect, away from their body. That's the size it would be when using the implant. I think it's a really common misconception that the implant will cause any sort of lengthening of the penis. So letting your patient know is always a good idea. Some disadvantages of the implant surgery can include the need for anesthesia and an operation. So there's always a risk of infection, typically less than 2%. Mechanical malfunction, it's usually around 10% over the first 10 years after implantation. But most patients are really satisfied after having their implant. So it can be a good option for those who may have tried the other erectile dysfunction treatments and are either non-responders or are not satisfied. And our final topic for today is information about the Prostate Cancer Supportive Care Program and the referral process. This program is a comprehensive survivorship program for prostate cancer patients and their partners, their family from the time of initial diagnosis onwards. And we offer education sessions, clinical support appointments, and have a research component in our program. And here's a quick look at those 7 modules we offer. Generally, we recommend the patient attends our group education session first. That is typically offered in person, though we're also doing online at the moment. And then for some modules, they may have the opportunity to sign up for a clinic with an appointment with a healthcare provider specialized in that area, such as exercise, nutrition, pelvic floor physiotherapy, or sexual health. And here's a little bit more information about my role as the sexual rehabilitation nurse. I run group education sessions. I do this for managing the impact of prostate cancer treatments on sexual function and intimacy, as well as recognition and management of treatment-related side effects of androgen deprivation therapy. So modules 2 and 4. And then these are just some of the many sexual health concerns that can be addressed in those one-on-one appointments. So if you have a prostate cancer patient who has some of these issues or more, I highly recommend referring them to our program, as there's lots of issues we can discuss in these appointments beyond erectile dysfunction. And here's the referral process. First, you'll complete your patient assessment, and after talking to the patient, you can provide them with some information about our program. We have info pamphlets in every team room under the label prostate cancer, so you can give the patient a pamphlet based on what they'd like more information about. And then notify the patient that if they are interested in attending one of our education sessions, the program coordinator can register them in the program. And this is information specific to Victoria. You can email bic.pcsc@bccancer.bc.ca with the patient name and their BC Cancer ID, and specifying which module or modules they are interested in. And here's my contact information and our program coordinator here at Victoria, Jessica Noble. If you have any questions about the program, I highly recommend asking Jessica. Anything sexual health related or ADT questions, you can definitely send me some information. And some take-home points that sexual health is an integral part of your patient's quality of life and overall well-being. Cancer and treatment can cause sexual dysfunction. Patients want you to ask about their sexual health, and you don't need to be an expert. Make sure that you're using the PLICIT model to help guide you, and seek out resources to help support your patients in their cancer journey. And here's my contact information again. If you have any questions or concerns, please feel free to contact me. Again, I highly recommend looking over that symptom management guideline for more information and looking at many of the other resources listed in this presentation. All right, thanks everyone for tuning in today. I hope I was able to answer some of your questions about sexual health, assessment, and prostate cancer supportive care. I hope you all have a good rest of your day.